Hello, I'm Luigi Barillo, and I'm here to talk about age-related macular degeneration, or AMD. Now, AMD is leading cause of decreased vision in the Western world. It tends to affect both eyes, and you rarely see it before the age of 45. Now, first, some anatomy. The central portion of the retina, which is a structure in the very back of the eye responsible for our vision, is the macula. This area of the retina measures approximately 5 millimeters in diameter. The very center of this is the fovea, and this is the area responsible for our fine vision. Now, there are two forms of AMD. There is the dry, which occurs 90% of the time, and there's the wet, which involves the growth of abnormal blood vessels. The pathophysiology of AMD involves senescence, or growing up, aging. And as we grow up, Bruch's membrane thickens. As this thickens, this presents a diffusion barrier for the choroidal vessels, which provide nutrition through Bruch's membrane to the overlying RPE cells. These are the retinal pigment epithelial cells. These RPE cells, in turn, take care of the overlying photoreceptors. In dry AMD, the RPE cells with age are less efficient, and with the thicker Bruch's membrane also become less efficient, and this leads to an accumulation of a substance called drusen, which can make things worse. And so the RPE cells are now able to get much less nutrition from the choroidal circulation, and in turn, they are unable to support the overlying photoreceptors or retinal cells. And so, because these cells, these photoreceptors, are not getting adequate nutrition, they can die off. In wet AMD, what happens is that the diseased or injured photoreceptors that are not getting the adequate nutrition release a substance, a chemical messenger called vascular endothelial growth factor. This substance can promote the abnormal growth of vessels from the choroid, those structures that, again, those vessels that are deep to the retina, which will then burst through Bruch's membrane, lead to bleeding and leaking and rapid visual loss. In dry AMD, again, we have the development of drusen. This is made up of lipofuscin, this yellowish substance, also known as colloid bodies. And this presents also as a diffusion barrier for the RPE cells. In dry AMD, there's a gradual loss of vision. And with time, there is a loss of enough photoreceptors and RPE cells that you have what's called geographic atrophy. And in the area where there's geographic atrophy, there is no vision. Now, once geographic atrophy has taken place, these patients have a difficult time recognizing faces and reading, and the light is either too bright or too dim. The light has to be just right. In wet AMD, we have abnormal blood vessels that leak and bleed in the subretinal space, and this eventually leads to the development of a scar, which destroys the overlying structures, including the photoreceptors. Here we have a schematic of choroidal neovascularization. Again, the vessels come from deep from the retina. They bust through this structure called Bruch's membrane, and they leak and bleed underneath the retina, leading to a scar. As this scar develops, there is an even greater diffusion barrier for nutrients, And so you have permanent visual loss take place. Here's a fluorescein angiogram of choroidal nevascularization. As you can see in the fluorescein, it is much easier to see these abnormal blood vessels. In this presentation, it's easier to detect the abnormal blood vessels with the bleeding. And over time, this bleeding becomes a thick disciform scar. And again, there are very few photoreceptors on top of this, and so there is loss of central vision. Now again, by history, those with dry AMD have a gradual loss of vision. Those with wet AMD tend to have a more sudden change. And again, these patients complain of having difficulty reading and recognizing faces. This is a representation of what a person afflicted with AMD may see, and there is a loss of central vision. We evaluate these patients with an Amsler grid as well as an eye chart. In a normal Amsler grid, the lines are straight. In an abnormal one, you will see patients often note distortions and loss of some of the lines. The risk factors for AMD include smoking and excessive exposure to sunlight. And how do we treat this? Well, we perform fluorescein angiography to determine the abnormal blood vessels. We also perform optical coherence tomography, or OCT. The current treatments involve the injection of anti-VEGF agents. These are antibodies directed against vascular endothelial growth factor. And there's also enrollment in studies which we'll touch upon. In dry AMD, there is no surgical treatment to date. Patients with dry AMD often benefit from the use of magnifiers, and vitamins may slow down the progression of the central loss of central vision. Again, vitamins have been found to be helpful in this condition. The AREDS2 formula includes vitamin C, lutein, zeaxanthin, and zinc. Wet AMD. One of the older treatments for wet AMD involved the argon laser. With this treatment, there is immediate loss of vision, and still in up to 50% of patients, the problem comes back. And so here we have a fluorescein angiogram. You see the abnormal blood vessels. They're treated with a laser. However, half the time, the abnormal blood vessels come back, and there's further loss of vision. Another past treatment for wet AMD involved photodynamic therapy. This includes the injection of a medication in the vein, and then it is activated in the eye with a selective cold laser. Then oxygen radical reactive species are created, and these cause coagulation of the abnormal blood vessels. The current treatment for wet AMD involves monthly injections with an anti-VEGF agent. There are many to choose from. However, it is very difficult to see a doctor every month, and it is very expensive. And with each injection carries the risk of infection, bleeding, and loss of the eye. And so we're exploring other methods to reduce this treatment burden. One of them includes state-of-the-art treatment with subretinal gene therapy. Here, genes are injected into the subretinal space, and the patient ends up making the anti-VEGF agent. In this case, it is similar to Lucentis or ranibizumab. To date, we have long-term follow-up on many patients, and they have done quite well. Some of the observations in the study include the development of RPE changes in the area that was involved with the gene therapy, but thankfully there are no significant associated intraocular inflammation, as with any gene therapy, inflammation is always a risk. And currently we are recruiting for 2 clinical trials. Here we are in the operating room.
There you go. You see it right there on the camera there?
Yes. See both right there? It looks almost about the same size. I think despite the...
There you go.
In this process, we perform a 3-port pars plana vitrectomy. We induce a posterior vitreous detachment by removing the gel, and then we inject into the subretinal space the gene therapy, approximately 0.2 mLs. This is using a 41 gauge cannula, and then we perform an air fluid exchange. So here we are performing a pars plana vitrectomy. We're putting in the ports. That's the infusion cannula. That's another cannula. And just in case you missed it the first time, here's the second time. Light. Put the lens in place, and then we introduce the vitrector. Here we're removing the gel. This is a very slow, methodical, and painstaking process. We have to be careful as the gel is attached to the retina, and sudden and abrupt movements can lead to a retinal tear or retinal detachment or injury to the retina that we don't want. So here we're trimming the gel in the periphery. We introduce a substance called triessence to just ensure that we've removed all the gel. And here we are introducing the 41 gauge subretinal cannula. And then we inject the substance, and you can see there the wheel is being made. There's a little bleb. We've injected the genes into the subretinal space, and here we are selecting another site not too far away, also inferiorly, and there we're injecting the medication or the gene therapy underneath the retina. Then we perform a partial air fluid exchange. This will help seal the little holes that we made, although those are self-sealing. And then we have the patient position upright during the night, and this will keep that fluid from going into the area where the vision is sharpest, or the macula. And here we are just closing the ports. In summary, age-related macular degeneration is a leading cause of blindness in the Western world. There are two forms. There's dry and there's wet. The earliest signs are these drusen that you can see in the back of the eye. Smoking and sunlight exposure are significant risk factors that should be avoided. And in cases where you suspect wet AMD, urgent referral to a retina specialist is recommended. Questions?